start or give 1 minute? I hope we have everybody join here. Just give a half a minute and see. It's right dot. I think we will start. And good evening, everyone. And thank you very much for joining us and able to attend this talk. This is something we have initiated to help collaborate with our family physicians and for the patients who are subsequently after the treatment are discharged for follow-up. And think the main reason behind this is to make sure that there is a continuity of care which flows from the cancer center to our colleagues in the community, and to address some of the questions or concerns which they may have. How and what about the follow-up? Some of the patients are still on certain kind of treatments. Some patients have still ongoing side effects, and how the scan should be done, what follow-up should be done, and there may be certain other questions which colleagues had and came up in the past. So we tried to address through these lecture series for different type of cancers. This is the second one of those series we are starting. We had the breast and was very, well received. We had the second one for colon cancer, and we had unfortunately changed the date, and we found a great response for this type of lecture. So before I go ahead, and this was just the background about these lectures, I would like to introduce our speaker, Dr. Adnan Zaidi, who graciously agreed to do this lecture. He is a medical oncologist. He's a clinical associate professor of medicine at University of Saskatchewan. And one of his major sites of treatment is colon cancer. So before I hand over to Dr. Zaidi, can we have next slide, please? Adnan, do you have a control for the next slide?
Yeah, so if you want to make medical oncology great again, this is the next slide. But I think you really want this slide.
Yes, yes. Yeah, sorry about that. Just a few housekeeping rules. We were just to make sure that you have a full, able to see this presentation, and everybody is able to, with a new thing which we're going through COVID is through WebEx, is to be able to hear everybody and not have much disturbances by our sides. So please make sure you are muted and your video is off. But when you are asking a question, you could raise a hand or put a smiley, and you could also put your comments on the chat box. We prefer that we could keep the question at the end, and we'll try to see whatever is coming in the chat. We will let Dr. Adnan Zaidi answer at the end. But if he has any other things or suggestions, probably you could put it in the chat box. So thank you, and I'll let Dr. Zaidi go ahead, please. Thank you.
So as you can tell, I'm a medical oncologist, and that's why this slide comes in. So, I mean, this is supposed to be more interactive, but unfortunately, I'm speaking and I can't really hear or interact. And I usually make my presentations in such a way that I can interact with the audience, but let's see how it goes. We are in the era of COVID and hopefully coming to the end of this soon. So we're talking about colorectal cancer today. And I mean, this is a big chunk of what we see. as far as the number of cases is concerned. And this is just from our website. And there is always a lag of a few years by the time statistics are put on the website. So I mean, it's right up there in terms of number of cases. I mean, it's actually one of the most common cancer, or if not the most common non-skin cancer, and also contributes to a significant burden in mortality. Maybe not as many deaths as in lung cancer, but part of the reason is that many of these cancers are diagnosed early and can have curative treatment. And this is kind of represented in the incidence by stage breakdown that we see. I mean, in lung cancer, we see a lot of stage 3, which end up becoming stage 4 or stage 4 cancers. But here, a significant chunk is where we can actually cure the patient. And the talk really addresses those patients where we have had or given curative treatment, and we are going to follow them, or the family doctors will follow them in the clinic. I mean, that starts with stage 1. I mean, we don't really see a lot of the stage 1 cancers. They're not usually referred to us, and I will address stage 1 cancer separately towards the end. But most of the data that we have, or the discussion, is mostly about stage 2 and stage 3 cancers. Stage 4 is also a separate category, and we will maybe address this towards the end. I think I have 1 or 2 slides about stage 4 cancers as well. So I have some trivia questions, and at the end of the presentation, Dr. Yadav will announce a grand prize. And I don't know, you can maybe type in your answers. So like, does anybody know who these 2 people are? And I'll pause for a second. And Sunil, you can, if you get the right answer, you can maybe read it out, because I am not monitoring the chat. So these are 2 actually medical oncologists and cancer researchers. You might not know them for what they have done for medical oncology, but these are the people and the brains behind BioNTech. And I mean, when you talk about the Pfizer vaccine, I mean, it's the Pfizer BioNTech vaccine. It was actually started, or the drug is BioNTech's. Pfizer is actually mass producing it and selling it, or distributing it. And sort of a second follow-up question, what is this? Is this like the vaccination in daily vaccination in Saskatchewan? It's actually the Pfizer BioNTech stock. And just a disclaimer, I don't invest in stock. This was just interesting. I was reading about these 2 people recently, and their story is quite interesting. They are a Turkish-German couple, husband and wife team, who are behind the BioNTech story. Okay, so the question is, why do we do surveillance? And the idea is that we want to detect people with asymptomatic recurrences, and we feel that these are the people who could potentially be eligible for curative surgery. And if you look at the data and analysis, there seems to be a survival benefit with such an approach. Overall, you may be able to cure or improve survival by another 10% by this intensive follow-up approach. So the idea is not to detect incurable disease early. So, I mean, we only do surveillance in cancers where we feel we can alter the course of the disease. So in colon cancer, there is a role of metastatectomy. We have data behind it. But in breast cancer, there is really no clear data behind the role of metastatectomy, although maybe the pendulum is shifting now with oligometastatic disease. But in breast cancer, typically, we don't really advise for a lot of intensive follow-up. The primary thing that we suggest is a mammogram, and that is to detect a new primary, or if there is a lumpectomy and the breast tissue is there, looking for recurrence in that area or a new primary in that area. But in colon cancer, what we are trying to do is to see if we can alter the course of the disease. And this can be applied to other cancers as well. So, I mean, if you look at one of those meta-analyses, this one, which was published a few years ago, looked at 4,000 patients, and they looked at stage 1 as well as stage 2 and 3 patients enrolled across 11 different trials. And they compared intensive follow-up with no follow-up. So intensive follow-up is differently defined based on the trial that you're following, but at least in this trial, they looked at history, physical examination with serum values, and basically what this means is a CEA level, as well as imaging of some sort and endoscopic evaluation and they compared that with no follow-up or very minimal follow-up. And there was, so if you did an intensive follow-up, it was associated with uh, you're much more likely to detect asymptomatic disease, and then that led to more likelihood of curative intent surgery. And that's kind of really what we are trying to go after. And the reason why that is possible is that in colon cancer, surveillance can lead to curative surgeries because most or a significant number of the recurrences happen in the liver and in the lung. And we have data that if you have limited or resectable disease in either the liver or the lung, survival rates can be as much as like 40% if patient undergo partial hepatectomy or resection of the pulmonary metastasis. We don't have good data, like let's say if the recurrences happened in lymph nodes in the belly or it was intraperitoneal recurrence, we don't have the same amount of data or the corresponding amount of data. So that recurrence may not carry the same importance. Um, and if you have multiple lesions in the liver, both lobes of the liver, multiple spots, surgery may not be possible. Again, that resection or that recurrence may not be resectable. But we are trying to reject is limited metastatic disease, mostly in the liver and lung. And outside that, the data for metastatectomy is not that well established. And we are just talking about colon cancer here. Um, So what exactly is intensive follow-up and how intensive it is intensive? And different studies have really defined it differently. So one of the studies looked at more intensive versus less intensive follow-up. And the most recent Cochrane meta-analysis suggested that there was really no survival advantage of the more intensive surveillance. So what do I mean by more intensive surveillance? That might mean doing a CT scan maybe twice a year, or maybe even 3 times a year, every 3 to 6 months, or doing a CEA every 2 months, or maybe doing scopes every 6 months. So that kind of intensive follow-up has not really been shown to be of additional value, and or is of limited value, maybe I should say. If you have a very high risk situation, maybe it might carry some weight, but most of the time doing very intensive surveillance is not very beneficial. And that is why guidelines really vary. So depending on who you're reading, there will be a difference in these follow-up guidelines. So if you read NCCN, which is one of the US National Cancer Network in the US, their guidelines may be somewhat different from the European Society of Medical Oncology, ESMO. And this is because of who you're reading or what you're following. Um, so I don't know, I mean, it seems like I'm talking. I mean, are there any questions, or like I don't get a sense of how this is going, or if there are any questions that are coming up? Or anything that is not clear. And Sunil, I don't know if there is anything in the chat
So
that.
I don't have any questions, but if they come up in the chat box, I would advise. But I think we have kept the questions for the end, so
Right.
probably we'll get most of the questions at the end, I assume.
Okay. I mean, it seems like I'm doing all the talking without sort of getting any uh, feedback, and I think this might end very quickly then. Okay, anyway, so what is the value of physical examination? I mean, we always advise, and if you look at most of the guidelines, whether it's our guideline or other Canadian guidelines or the US guidelines, there's always that physical examination should be a part of any guideline. But if you really look down and look at the data more carefully, it's questionable what is actually the value of a physical examination. So this study that I'm quoting here These were around 1,300 patients or 1,356 patients. These were stage 2 and stage 3 patients followed up on an intergroup trial after they have had adjuvant chemotherapy. And maybe a third of them, 421 patients, developed disease recurrence. And out of those, 96 or almost 100 of them were able to undergo surgical resection with curative intent. And if we look at extrapolate from what we know, maybe 40% of them would be cured by this. But unfortunately, physical examination failed to identify a single resectable recurrence. And part of that is that recurrences quite often happen within the abdomen, in the liver, or in the lung. Um, and these are areas which are not very amenable to physical examination unless you have extensive disease. And by that time, usually that means is that these patients are not really resectable. So, I mean, the value of physical examination is questionable in this situation, but most authorities would suggest, and most guidelines would have them somewhere, that you should do a physical examination every 3 to 6 months. Um, the thing that is most commonly recommended is actually a CT scan. And you can debate whether it's, depending on where you live, which part of the world you live, whether a CT scan is absolutely necessary or whether an ultrasound of the liver could be done if you are in a resource poor country or a region. But some sort of imaging has been shown to be of significant value. And the most common recommendation is to consider doing an annual CT. So if this is colon cancer, most guidelines suggest that doing at least abdomen, chest and abdomen. If it is rectum, then they suggest doing pelvis as well, as far as the CT scans is concerned. But most of the time we end up getting a CT scan of the chest, abdomen, pelvis, all three of them. Um, and that is most of the value of CT scans is within the first 3 years. So most recurrences happen within the first 3 years of their diagnosis, and that's where this magical number of 3 years comes in. And again, you should do scans or do imaging for people who are candidates for aggressive therapy. So if you have a patient who is um, not in the best of shape, somebody in their 80s or 90s, well, age actually is not absolute indication. It's how they are biologically. And if they are not candidates for um, metastatectomy and they're in poor physical health, or they have other things which are really weighing them down, then this recommendation could be modified. And I mean, we do scans, or we recommend scans for patients where we can operate on them and do perform a metastatectomy. And these guidelines are also endorsed by ASCO and NCCN, which is, again, ASCO is American Society of Clinical Oncology, and NCCN is the National Comprehensive Cancer Network. Both of them are US based entities. I will come to our recommendations as well in a little bit. Okay, so the other thing that we quite often recommend is a CEA, which is carcinoembryonic antigen. Now, CEA is not specific to colon cancer. It can be elevated by other things. People who smoke may have a higher level of CEA. And CEA is not always elevated. So if you have metastatic disease, maybe 80% of the people will have an elevated CEA, but not everybody with metastatic disease would have an elevated CEA. If you have localized disease where you're operating on, I mean, maybe 20% of the patients would have an elevated CEA. The value of CEA lies because there is usually a gap. CEA is quite often the first thing to start becoming elevated, and there can be a gap of a few months before you see a CEA rise, and then you see something on imaging. There can be a gap of 1 to 6 months on this. The problems with CA, as we are already talking about, is that some of these recurrences are not associated with elevations of CEA. Maybe a third of the recurrences may not have elevated CEA. it is unclear if CEA testing improves survival. I mean, yes, you can extrapolate that CEA can lead to limited or isolated recurrences, which in turn can go to have a curative intent surgery, and those 40% of those patients may be cured. But CEA independently has not been shown to improve survival. Another word of caution. I mean, we don't, or we try not to order CAs while people are going through adjuvant chemotherapy, and CA can be falsely elevated, and that can lead to a wild goose chase on patients who are actually getting adjuvant chemotherapy, 5FU based chemotherapy. So the CA monitoring happens once they have completed their 3 or 6 months of the adjuvant treatment that they are getting. Now, this could be somewhat modified in rectal cancers, where you're doing uh, a total new adjuvant approach. So you start off with chemotherapy and you have a high CEA, and if you want to monitor that, I mean, you could consider following CEA, but most of the value of CEA arises or is in the follow-up setting once you have had curative intent treatment. CEA, and in fact, and that's true for most other things, is not a substitute for a biopsy. And CEA could also be elevated in other conditions other than colorectal cancer. The other thing that we advise is a colonoscopy. So colonoscopy now, quite often, especially resectable colon cancer, which usually means stage 1 to 3 colon cancer, is detected on a colonoscopy or a sigmoidoscopy. But quite often you hear, or you see, if you read the report, there is this suggestion that the tumor is circumferential and they're not able to pass the scope beyond the tumor. And the reason why that one line is important is because there can be a number of cases, number of patients where there could be a synchronous primary. So in addition to what you're seeing, there could be another primary colon cancer, and that can be seen up to 2 to 5% of the patients. So it is important to really fully visualize the colon. And if you're not able to do that at the outset, you consider doing it as soon as it is technically feasible or possible. The other thing, so this is around the time of the operation or before they are considered for surgery. But when it comes to surveillance colonoscopy, what we are trying to see is to detect additional colon cancers. So somebody who has developed colon cancer in one part of the colon or rectum, they are at risk for developing other cancers over the next few years. And we know that many of these or most of these arise from polyps. So we are hoping that we could catch those polyps or cancer early and before they can cause more damage. So a surveillance colonoscopy is typically recommended. And of those, the most important one is the scope 1 year post-op, or roughly around 1 year post-op. That's really the one that is most important and is most likely to catch something. So metachronous or subsequent lesions most likely develop in the first 3 years post-operatively, and the rate is much higher initially, and that sort of falls off. And some of it may be that some of those were present, polyps or cancers were present at the time of the initial diagnosis, but were not really picked up. And the rate is much higher initially. Anastomotic recurrences, although if you read the literature, it's supposed to be 2 to 4% in colon cancer, but I think maybe the numbers are even lower. It is very unusual. If you work with a good colorectal surgery team, it is very unusual to see anastomotic recurrences in the colon. And the recurrences are much higher in the rectum, especially if you do not have a total mesorectal excision, which is called TME, which is the current surgical technique, and if you have no radiation. And most of our, almost all of our patients would be treated with TME and would have radiation in the operative management or the perioperative management of rectal cancers. But still, I mean, another reason why we do colonoscopy or a follow-up scope is to look at recurrences, whether locally in the rectum or else or in the colon. Okay, so I mean, again, this was supposed to be interactive, and if you feel free to write your responses. So what are the things that you don't think would be recommended? Um, and maybe Sunil, if somebody does type in any responses, you can read them aloud. So we are recommending doing a CEA. We are recommending doing a scope. We are recommending doing a CT scan. But what things which would you not do in the follow-up of colon cancer? I will pause for a second. And
So, Adnan, I just want to give you a feedback. I'm waiting for comments, but people have said PET scan.
okay.
Yeah, and also there are comments that your talk is very engaging and it's going well. So don't worry, people are listening.
Okay, good.
More questions.
Okay, anything else other than a PET scan? I saw that, like anything else that you would not do in the follow-up of colon cancer. So, I mean, I ask this to medical students all the time, and when I'm talking to them. So, other things that you probably would not do is a CBC. I mean, I'm talking about just about follow-up of colon cancer, not talking about routine CBCs that you guys would order as family doctors in the follow-up of your patients. So CBC, I mean, if you're looking for bleeding and if you're concerned that this patient has developed cancer, may develop um, bleeding again, CBC is not a very good way of assessing this. And especially if you are going to do a scope every now and then, CBC is not really recommended. Liver function tests. So as we just talked about, that many of the recurrences happen in the liver, and um, you, so logically it might seem that performing liver function test every 3 or 4 months might be useful, and there may be some abnormalities in the liver function which might lead to you to do scans or CT scan or an ultrasound. But I mean, liver has a lot of spare capacity. I mean, when you read the literature on metastatectomy and liver resection, you can remove almost 80% of the liver, and you could still that's still compatible with life, and liver will regenerate over time. So you need to have a lot of cancer in the liver before your liver function tests start becoming abnormal, or cancer in the wrong space, like cancer right next to the biliary ducts, or somehow or the other that it is affecting the flow of bile. But liver function tests are not recommended because they have really never been shown to add value to in addition to the CT scan or the CEA or the other tests that we are talking about. Now, FIT or looking for blood in the stools is also not recommended, largely because you are going to follow these patients with a scope. So if for some reason a patient doesn't want a scope, then you could consider doing FIT. But otherwise, a FIT, this test is not recommended in the follow-up of colon cancer. And one other thing that I have seen this a few times, if you have somebody who is coming to you as a family doctor and is complaining of blood in the stools, FIT is not a good test at that point. It is not recommended. You should trust your patient and I mean, follow it up with a scope. FIT is a good screening test, which means that if you have no symptoms, then it is a good test to do. But if your patient is already coming with blood in the stools and they're concerned, and you're concerned about colon cancer, then FIT is not a good test, because and bleeding can be intermittent, and you can it can be negative, and there may be cancer hiding there, which may present if the patient is already presenting with obvious bleeding. And then the answer to that was the PET scan. PET scan is the right answer. PET scan have not been shown to add value in the follow-up of colon cancer, colorectal cancer, and they do not give any additional information than a CT scan would provide. Now, if you want to clarify something, um, uh, obviously we're not recommending that we do PET scans at this time. Okay, so this is another kind of trivia question. Which company has only one commercial product but is worth 78 billion? Uh, Anybody wants to uh, give an answer? I mean, this is not a fair question, obviously, but it's in the COVID theme that we are talking about. So it's Moderna, and they have only one product which they have brought to market since they started working, which is the Moderna vaccine. And I mean, I don't know if anybody knows what Moderna stands for, but Moderna is really modified RNA. So both the BioNTech also, one of their main areas of interest is RNA research, and Moderna is also modified RNA, and I think the stock symbol is also mRNA, which is interesting. And again, I'm not suggesting that we invest in anything. And I have no stocks of either company. I actually don't invest in stocks at all. So what about anything new on the horizon? So far we have been talking about CT scans, physical examination, whatever the value of physical examination might be, and CEA, and colonoscopies, but anything new on the horizon. And so the newer kick on the block is this circulating tumor DNA. So tumors can shed their DNA, or sometimes even the whole cells can come out into the bloodstream, and they can be detected by really powerful assays. So we can detect circulating tumor DNA or circulating tumor cells. And in colon cancer, we have more data with circulating tumor DNA, and they can be an extremely powerful indicator for relapse. If you detect them, then you are much more likely to relapse with cancer. And so if you look at one of the studies, and there are lots of studies actually in this space, they looked at 125 patients, and they looked at both stage 1, 2, and 3 cancers, and looked at circulating tumor DNA. And people who were positive for circulating tumor DNA were 40 times more likely to have a recurrence or experience a disease recurrence. And their relapse rate, according to this study, was close to 100%. Whereas if you were negative for circulating tumor DNA, the relapse rate was around 14%. So part of this is that circulating tumor DNA is a very powerful indicator of relapse, but it's not, again, it's not 100%, and not all tumors shed DNA or come out into the bloodstream that can be detected. The problem with circulating tumor DNA in 2021 is that it's not ready for prime time. So if you do have a patient, and I've had occasional patients who have sent their blood to the US for this circulating tumor DNA analysis, um, then what do you do with that information? So if it is elevated, like, do you give them a longer course of chemotherapy, or if it is negative, do you not give them chemotherapy? And those trials are actually being conducted right now. There is a trial that was floated, the idea was floated, and it's making its way, it's slowly being started across Canada. This is done by CCTG, which is the Canadian Clinical Trials Group. And what they are trying to do is that if you are circulating tumor DNA positive after surgery, maybe you should get more intense chemotherapy. So if your plan was to give somebody no chemotherapy because they were stage 2, but now they are positive for circulating tumor DNA, maybe you should give them 3 or 6 months of chemotherapy. Or if you were going to give them 3 months of chemotherapy, maybe you should consider giving them 6 months of chemo. And if you are negative for circulating tumor DNA for stage 3 cancer, then maybe you should consider de-escalating chemotherapy. So if you were thinking of 6 months of chemo, consider doing 3 months of chemo. And if you were thinking of 3 months of chemotherapy, then maybe consider not doing chemotherapy. So it's a sort of a bold, provocative trial design. But right now, we really don't know what to do with this information if you do have positive or negative circulating tumor DNA after surgery, or more problematically, after the completion of adjuvant therapy. Like, what do you do with that information? Okay, so I briefly touched upon this. So most of the patients that we see and most of the data that we have is really for stage 2 and stage 3 cancers. Uh, Many stage 1 cancers are not referred to us, and surgeons know that we will not be offering them adjuvant chemotherapy, and they discharge these patients directly back to the family doctor. And most of these patients would be cured by surgery alone. Sorry, there's a announcement going on. I'm just going to pause for a second. Okay, so um, so anyway, I'll keep going. So anyway, um, there is still a benefit for following these stage 1 cancers. Um, the benefit is small just because the likelihood of recurrence is very low. But if you follow all of these patients with imaging CA, you will be able to cure maybe less than 1% of them. So you will have to follow a lot of those patients to get to that 1%, one patient, or even less than one in 100 to get to that one patient who would be cured. Um, but but there is still a benefit to of following stage 1 patients. But because the benefit is so small, the surveillance is actually controversial, and different entities have described different. So if you look at Cancer Care Ontario, they don't recommend following stage 1. They don't recommend suggest doing anything for stage 1 cancers. uh, NCCN, which is again the US entity, they don't, uh, they say suggest no follow up for colon cancer, but for if this is rectal cancer, because rectal cancers are at a higher risk of especially local recurrence, and we don't give them chemotherapy. Well, we don't give chemotherapy to even colon cancers, but they recommend that we do follow up the rectal cancer patients. ESMO, European Society of Medical Oncology, recommends that we follow up. We follow the same recommendations for stage 1 cancers as well. What about stage 4 disease? So as we are trying to identify patients who can have metastatectomy. I mean, there are some patients who are diagnosed with stage 4 disease and have metastatectomy to begin with, or they may follow or fall into this area um, after they have been on surveillance. So really, there's no good data in this group, but we know, or obviously this is a group, this is much more likely to have a recurrence, and in a very high risk group. So the strategy for this group needs to be individualized. And but if they are candidates for additional surgery, I mean, they it will be most of these patients are actually followed by the oncologist. We don't discharge these patients for quite some time, and we would follow them with imaging, and usually that imaging is more frequent than one scan a year. But this is not really driven by a lot of good data behind it. Okay, so this is another trivia question. What happened on December 23rd, 1971? And I mean, you can Google it, and it's not my birthday. um, so I'll give you a clue. Um, okay, maybe I'll just answer this question myself. So, I mean, the longest war the US has been involved in is actually the war on cancer. So this was the day that President Nixon declared war on cancer and signed the National Cancer Act. Um, and so it's been like almost 50 years since then. And I mean, we have made a huge amounts of progress with this war on cancer. And I mean, this is not a talk about immunotherapy, but one of the great things that has happened is immunotherapy. But we are still in that war against cancer. And US, I mean, in the US, they always think of in terms of war terms. I mean, everything is considered as war. So sorry. So coming back to Canada and coming back to Western Canada. So there is a GI conference that happens every year, and this is Western Canadian provinces. So this is Manitoba, Saskatchewan, Alberta, and BC. And we meet once a year. And with COVID, we are meeting virtually for a shorter duration several times in the last year. But typically, it would be over two days. And usually, we have questions that we would bring up. And so the conference in 2018 was actually in Saskatoon. And the question, one of the so at the end of the conference, we come up with a consensus statement. And one of the questions for the 2018 consensus conference was, what is the optimal follow-up of early stage colorectal cancer? And this is our consensus statement, which all of the provinces agreed upon. And some of it is dictated by what people are doing, and some people want to do less, and so and they want to be include everything. So the consensus statement included patients with stage 1 to 3. So it was all comers, or all stages, including stage 1. And surveillance should be considered for patients who are stage 1 to 3, who are candidates for salvage surgery. So the second part is really important, that they need to be candidates for salvage surgery. And if they're not candidates, then maybe we shouldn't do any surveillance. And again, follow-up could be done. I mean, in most jurisdictions, these patients are increasingly being discharged to primary care providers. And CEA testing is every 3 to 6 months for the first 3 years, and then twice a year till year 5. Um, and if there is a rise in CEA, that probably warrants additional workup and maybe a more frequent scan. The if you read the next bullet, it is consider periodic clinical exam. It is very hard not to exclude it, but the value of physical examination is somewhat debatable, and that's why it was put in with a qualifier: consider periodic clinical assessment. Then this line about CT scan is CT scan of chest, abdomen, pelvis, and again you could decide whether it's pelvis is indicated or not, but most often we would end up doing a scan of everything. And now here they say twice in the first 3 years. So I didn't go through this study, but there is at least one study indicating that if you do just 2 scans in 3 years, that is as good as doing a scan, one scan a year. So I mean, most of us are still considering, or may still recommend doing a scan once a year for the first 3 years, but you could also maybe do just 2 scans in the first 3 years. And then follow-up colonoscopy is really important, especially the 1 year post-op colonoscopy is really important. And then it could be done every 3 to 5 years. So if the 1 year colonoscopy shows multiple polyps, then you may need to do another one in 6 to 12 months. But if it is very good, if the preparation was very good, the surgeon was very happy that he didn't miss, surgeon or gastroenterologist or whoever did the scope was very happy with the bowel prep, then 3 to 5 years is okay. If there were problems with the prep, or if there were problems, there was something found out, then you might need to do it more frequently. So if you look at the Saskatchewan Cancer Agency website, and if you look at the stage 1, so there is a slightly different take for stage 1. And in stage 1, our website is recommending that we should consider following these patients with exam, CEA, scope. There is no recommendation for a CT scan. And again, this could be individualized. So if you have a young patient who is otherwise very well and wants intensive follow-up, then you could consider doing a CT. But this is kind of one of those gray areas where you could debate whether a CT scan is indicated or not. Scope is definitely indicated. If you have a younger patient, you should definitely look for new polyps or new primaries. CEA is easy to do, not very expensive. An exam is, I guess, easy to do, but the value is questionable. Now, if this was stage 2 or stage 3, then our website recommends doing a CEA as well as a CT scan, as well as a colonoscopy or a scope of some sort. Now, one thing which is a little bit interesting, and this, I talked to my colleagues about it. So when do you start doing these things? Do you start them from the time of their surgery, or at the end of the cancer treatment. And if you look at most of the data, it is from the surgery. But by the time you are done with the additional chemotherapy, you've tagged 6 more months to it, because most of the time uh, chemotherapy is either 3 or 6 months. So usually it's 6 months. Anyway, most of the time that we start recommending, or I mean, I've talked to most of my colleagues, I think they would suggest consider these investigations from the end of treatment rather than from surgery. But you would not be wrong if you started counting the clock from the day of their operation. And most of the guidelines and the data behind that is based on scans which start after surgery, or the clock would start after surgery. I mean, I was told I have 15 minutes left, but I think I'm coming towards the end of it. So what about relatives? So this is something I think family doctors may even know this better than I do. I mean, what I tell my patients is that, so I ask them if they have siblings. So if you have a 45-year-old who has a 42-year-old sibling, I ask them if they want to share this information, they should let their brothers and sisters or family members know, and they should contact their family members. They should contact their family doctors about what needs to happen next, and should they be scoped, and should they be followed up. And the answer is yes. Uh, uh, First degree relatives, and first degree relatives means siblings, children, parents, uh, should be screened. And screening, I mean, so I tried to look up what is the Canadian recommendation, and I had difficulty finding it. But looking at the American recommendations, they suggest that start screening with whatever methods are available at the age of 40. And I mean, a lot of them actually suggest screening with a scope, a colonoscopy. Um, and the reason, I mean, historically, we have recommended that if you have a family member who's diagnosed at the age of 54, you should start screening family members 10 years earlier. So maybe at the age of 44. And the rationale behind that is that if you have an average risk cancer, like if you don't have a familial polyposis type of cancer, it can take 6 to 10 years for a polyp to develop into cancer. And so that's where the 10-year mark comes in, and you start 10 years earlier. So you would scope or screen those patients 10 years at the age of 40, or 10 years younger with the index patient. Now, the criteria or the hereditary syndromes, there are some patients who have a strong family history of colon cancer. So if they have one of those hereditary polyposis syndrome, then they start developing polyps at a very early age, and they can be hundreds or thousands of polyps. And if you're going to screen them, you have to really start screening in their teens or 20s. And hopefully they have been identified because of the presence of colon cancer in their family members. But because you have hundreds of polyps, you can very easily miss colon cancer, and quite often the recommendation might be to have a total colectomy done. So we're not talking about those patients, but we're talking about the other group which has a higher risk of colon cancer, which is the Lynch syndrome or the hereditary non-polyposis. And that criteria has a sort of changed over time. Uh, I mean, we used to refer to the Amsterdam criteria based on the family history, and there is also a revised Bethesda guideline. But increasingly, we rely and those guidelines are still they can still be used. But now, uh, I think in the last 6 to 12 months, almost all colon cancer patients that we see for stage 2 and stage 3, they have MSI testing, microsatellite instability testing, done by immunohistochemistry. This testing could also be done by gene panel testing. And if you have MSI high, then you could do a subsequent, I mean, I typically would order or consider adding BRAF mutation. Now, these tests were not done, I mean, we have started just doing them in the last 6 to 12 months. So this is maybe something new that we are not fully following up. But if they are negative for BRAF, then they need to be referred to genetics, and they can look up the Lynch syndrome, or they can screen them or identify those patients who have Lynch syndrome. So staying with the COVID theme, let's talk about the side effect of the chemotherapy. And there's just one side effect that I really want to talk about, and it's not blood clots. So AstraZeneca, unfortunately, has had a really bad press. It's a sort of an unfortunate situation. It's a reasonably good vaccine, very cheap, but nobody wants to have it. And interestingly, actually, AstraZeneca, and this is again just like useless trivia, AstraZeneca invested like close to $250 million in Moderna many years ago, and they never got a, this was not for any molecule, it was just for any future molecules that might come up based on their the direction that they were taking together as their two companies, and this definitely did not include the COVID vaccine, and they never got anything out of that $250 million. Moderna got their vaccine. So the toxicity that I really want to talk about is this is, I am sure as family doctors, you have all dealt with this. This is the neuropathy that is associated with oxaliplatin. I mean, unfortunately, as you go up and you repeat oxaliplatin as part of FOLFOX or KPOX, the risk increases with the number of cycles that the patient has received. And unfortunately, in some cases, this neuropathy can actually get worse even after you complete treatment. So there are guidelines that if you start developing neuropathy while you're on chemotherapy, you could cut the dose of oxaliplatin or just abandon it altogether, because this can be quite problematic. And as oncologists, we know that elderly patients who may have problems with balance or may have other issues that we may not want to use oxaliplatin in them anyway. And this is also true for diabetics or other people who have pre-existing neuropathy. The literature suggests that it is reversible. I mean, whether it goes down all the way back to normal or it reverses to a partial extent, but majority of the cases, there can be some degree or a significant degree of reversal that we would see. But there is a certain number of patients who would have this. We have a grade for neuropathy, and this grade is there. And I mean, there's nothing. I mean, the risk of neuropathy goes up as you look at give more, and you're very concerned about grade 3 neuropathy, which happens in a small number of patients, but almost all patients, 80 to 100% of patients, would develop some degree of neuropathy. And there is no magic treatment that I have. You can try gabapentin or Lyrica or like treatments that you would normally use for this. And we don't really have anything that we can do to reverse this. I think this is my last slide. So West Virginia has some incentives for people who are not getting vaccines. And this is the grand prize is the 1.5, almost $1.6 million. They're giving away trucks, rifles, shotguns. So, I mean, surveillance is appropriate for patients who are candidates for metastatectomy. Mostly it is to do with stage 2 and stage 3 patients. Most recurrences happen in the first 3 years, and a smaller number would happen in year 4 and 5. Neuropathy is actually the most common side effect with adjuvant chemotherapy. Thank you.
Thank you, Adnan. That was a great presentation, very engaging, and we had few comments from the audience. Looks like people have really enjoyed your presentation. I have one question, couple of comments here.
Okay.
One comment was that when you were telling about the physical examination studies, and the comment is that people will not be very comfortable not laying eyes or hands on the patient. So, about not doing a physical examination.
Right. So despite that, I think almost all guidelines suggest or include some sort of physical examination. I mean, even if we as physicians are convinced, many of our patients would demand or would want us to do a physical examination. So I think it's still there in all the guidelines, but the value is somewhat questionable.
And is if anybody has they want to want to speak up their question, they are welcome to. They don't have to put in the chat box. You're welcome to you know I see there is a question from Naseem. Please go ahead, Naseem. Your hand is up. Maybe the hand was up by mistake. Um, so if there are not any questions, we are coming to end, and I will see again in the chat box if there is any questions. No, I think it's they really liked your presentation, Adnan.
So I think there is one hand. I don't know. This is Dr. Khanna is asking, raising his hand. I
Yeah,
think that was.
I just had a question. You said that neuropathy is uh, usually reversible from the chemo. Is that spontaneously or like with time or again with medication?
So no, there's nothing that we can give which can reverse the neuropathy. So it may fade over time. And I mean, previously there was some suggestion that like giving magnesium infusions may help, but nothing really has panned out. So the first thing would be to prevent it from getting really worse, which is what we try to assess while they're on chemotherapy, and make sure that it doesn't get to that point. And then if and sometimes it gets worse after you stop the treatment or you're done with the treatment. So I mean, I think these things, Neurontin may help. And the reason I generally ask family doctors, and usually they're very good at doing this, is because it needs to be titrated up. Like you may start at a slower dose and you may titrate it up and see if that is helpful. But it doesn't, there's no medication that would reverse it. It is kind of on its own. It may fade over time, and it's not always reversible. It is usually reversible, but not fully reversible. So the reversal may also be partial.
Can we start gabapentin while the patient is getting the chemotherapy?
I don't think there would be any contraindication. The only thing that would make it difficult to assess, so I think if they're at a point where they need to go on gabapentin, they shouldn't be on oxaliplatin. Otherwise, it would be difficult to assess if they have minor neuropathy and we are continuing with oxaliplatin. It might be difficult to assess. We might be continuing with an agent which might be causing problems, which may not really be a good idea. But
Thank you.
if they're that bad, they really shouldn't be on oxaliplatin. We should be stopping it. And we're talking about adjuvant setting. Now we may consider, we may have different thresholds for metastatic disease. If we have colorectal cancer, the patients with metastatic disease, if they have no other options, then we might sometimes consider continuing with oxali if it is working and we have no other realistic options.
Thank you.
I don't see any other hands. So
I don't know if I mean, I just wanted maybe one of the family docs make what is their take on I mean are there most of their patients getting the COVID vaccine, or is there some resistance to it? I mean, that's just some interesting this is not related to this talk. Somebody wants to, I mean, we have been advising people to get um, uh, the vaccine, and we have been modifying the chemotherapy for metastatic patients, even holding it for a few days to allow them to. We have been really encouraging our patients to get it. So I think, I mean, if we can have the same
yeah, I see
similar.
a hand from Samantha. Go ahead, please.
Hey, good evening. Thank you for a good talk. I caught 99% of it. I still had a patient beforehand. Just from the COVID part, most patients have been pretty good, but I do have a conspiracy theory person amongst them, like everybody else does. And The current thing is this whole new data supposedly coming out of Japan saying that there's spike proteins in the vaccine that's binding to all parts of the body, including ovaries and the brain. So I'm just waiting for the information for that to come out and decide what to do about that. I don't know if anyone else has heard about it. I was just made aware of it yesterday. I haven't looked too much into it, but it sounds like this is potentially another story that's, I guess, coming to light.
Yeah, I'm not the content expert on that, so I will not venture anything, say anything.
Yeah, I haven't seen anything until yesterday, so I just wasn't sure if anyone else knew about this, and I was like just the last to know. But they've been actually really good. I've had very little resistance from patients, and most of them were just nervous because of the mRNA and the whole, the novelty of it. And as soon as they found out that I was nervous and then I was good and got mine and I survived, they've all been getting theirs. It's been really reassuring from that point of view.
It just tells that family doctors have a great influence on the patient decisions. And,
I mean,
I've seen that in our clinics.
I would second that. I mean, sometimes, I would advise them something like chemotherapy and they would say, okay, I'll go and talk to my family doctor. And so you guys have known them for years at times, and we sort of somehow suddenly jump in, and they would say, okay, we want to talk to them before we make any decisions. So which is really goes to show how much trust and faith they have in you guys. Okay, good. Thank you.
I see another hand from Geeta, and probably, maybe I think we are coming to an end. So Geeta, go ahead, please.
That thing about the spike protein and it attaching to thing, Kevin Wasco actually had posted an article somewhere, and I think it was at one of the town hall meetings, and I think that's been debunked on the fertility thing. Is that it? It is somewhere. If I find it, I can email it to whoever to share. So I thought I have heard it, and that has been addressed somewhere. So.
Yeah, it has been. The fertility thing has been debunked.
Yeah.
Okay, that is good, because I knew they weren't worried about fertility before, but when there was apparently a YouTube video that was only posted about 2 days ago, and I'm like, okay, am I behind on this? Have I missed something? Is it new? And I haven't obviously gone any further. I'll see if I can put my email address into a chat box. I'm just on my phone, so it's kind of difficult. But if you could take it down and email it, I would be most appreciative, so I can start tracking this backwards.
Thank you so much. It was a great discussion, very engaging, and thanks everybody for joining in. For the last about the certificates and how the CME, Heather, do you have any comments to make? Last comments to make? I don't know if Heather could. We can't hear you, Heather. Do you have anything to say about the CME? Any CME information? Okay, I guess we are not able to hear Heather, but we could follow up with you guys regarding the CME and there's any feedback surveys. And have a great evening. Thank you so much.
And thank you for attending the talk. Thank you.
Yeah, Heather
Thank
said,
you.
yeah, I'll go out in a few weeks.